Dr. Bill Adams here. This is a No Spin Live one-on-one. I'm here with the great Tom Wiener. Tom, fantastic job last night on the Aesthetic Society webinar. You talked about the data and the science. And I can't tell you how many calls I've gotten from members who just thought it was so clear and concise and they really enjoyed it. So thanks so much. Tom's south of me in Houston. How are you?
I'm doing good. We got lots of good data to discuss today.
We've been talking a lot today, so I'm sure this is going to be, it'll be another barn burner. But I have a few questions. I'm just going to pitch them out to you and let you educate us. But so you hear a lot about a pandemic. Tell us, Tom, what a pandemic is.
Well, that's important to know and difficult to find because there's no clear definition of the term pandemic. The overall definition is something that is global, a disease or a virus that's global. I looked on the CDC and they more or less said that when an infectious agent is worldwide, however, it's only for novel or new infections or viruses. So when we're all frightened and hear this word pandemic about COVID, it's because by definition, the seasonal flu, the flu every year, which every year is much greater than the COVID numbers, those numbers for the flu are all pandemic, but they're not included in the definition of pandemic. That's why you never hear about them every single year, every minute, every hour, like you do the COVID numbers. So the numbers currently for the flu would obviously be considered pandemic if they were for any other disease that was novel. Okay,
very good, very, very clear. All right, so the fundamental question that everybody's wondering about, okay, what is this new virus? You know, is it, people know about the flu, although I'm not really sure they actually know how serious the flu still is and what the morbidity and mortality of it is. But the fundamental question is this virus really more dangerous than other viruses that are out there? There's 108 viruses, the flu has 29 strains, but the science and data tells us a lot. So tell us about that, Tom.
Well, if you look on TV or social media, you would think that globally everyone's going to be dead in a couple of days, but that's clearly not the case. What you're saying is this is an inundation of exposure about COVID. Like I said, every minute, every hour, every update on Facebook or Instagram is about a new death, a new case. And what we don't hear are the numbers about the seasonal flu, which are drastically different. So it's important to really start from the beginning. COVID is really primarily a disease, even though it's widespread, it's a disease of hotspots, and that's what we're seeing. So we see hotspots such as New York City, which has very high numbers of COVID, but once again, lower than the flu. However, the media focuses on these hotspots, especially a media that's focused on New York City. COVID is new and novel, and one of the important reasons for that and how it's spread and why it's occurring in hotspots is how it's developed, how it's spread, and this has everything to do with travel and tourism. So this virus first was identified in Wuhan, China, spread quickly to the United States and Italy. Now, interestingly enough, outside of Asia, the most common area for Chinese tourists to go are the United States and Italy. Most Chinese tourists to Italy, importantly, travel to the northern and the central districts of Italy, which was the big hotspot for COVID. In 2019, airport arrivals in Italy from China grew 16%. Now, those arrivals, that was 2.8% higher than arrivals from all other countries combined. So they were getting a lot of Chinese tourists, obviously some that most likely had COVID. The numbers were so high as far as tourism from China that in 2019, 2020 was designated as the China-Italy Year of Culture and Tourism. So those are big numbers. In the United States, now we went from China to Italy. Now let's talk about China and Italy to the United States. From Italy specifically, in the United States, the highest Italian American populations are in New York and New Jersey. Interestingly enough, those two states have over half the United States deaths from COVID. Very important to look at that. New York City has the highest number of Italian Americans of any city in the United States, with about 1.8 million. These numbers are actually a little old, so it's most likely higher. The next highest city, Philadelphia, only has 497,000. So that's the New York City. New York City has a huge population of Italian Americans, indicating a higher level of travel from Italy to New York. Interestingly enough, New Orleans is relatively high on the list with an Italian American population of about 250,000. We saw that with that blip that occurred, not so bad now, especially because of Mardi Gras and the tourism that occurred with that. So these numbers indicate a population movement from Italy to the United States, and why New York was hit so hard, or part of the reason New York was hit so hard, along with their higher population density in New York City and what we've discussed, viral load. On the West Coast, travel from China is common to Los Angeles. As a matter of fact, Los Angeles is the city with the second highest Chinese population. Number one, not surprisingly, number one city in the U.S., New York City for Chinese population. So they had sort of a double whammy as far as influx from two major areas where the COVID was becoming important. The next thing we have to look at is, as far as which one is more dangerous, which one is more deadly. Let's start with the flu and how it's reported. I took a look at all of the different or various state health department reporting requirements. The flu, interestingly enough, there's no requirement to report individual or common flu positive testing or even mortality, deaths. The only requirement that it was in most of the state health departments was to require reporting of the flu pediatric deaths, also cases of variant or novel flu, and also areas that have major large flu outbreaks. So that's really it. Now which one is actually worse? The big scare has been really hospitalization use. Or hospital use, and that's an indicator of how many people are really sick. So which is worse, COVID or the flu? Well, the important numbers here are for the flu, the hospitalization rate is 68 per 100,000 people. That's for the flu. Now, it was hard to put this number together for COVID, so I decided to pick the worst case scenario. Which area is worse for COVID? That's New York City. They have most of the cases. So for New York City, which is the worst case scenario, the hospitalization rate for COVID is 20 out of 100,000. So the flu, 68 out of 100,000, COVID, 20 out of 100,000. So a lot more hospitalizations for the flu. And that's in the face of the flu having a vaccine, and with the flu being technically underreported because the health departments don't require much of that. As of March 1st, 1% of all deaths in the United States, for any reason whatsoever, were actually caused by the flu this season. To compare the flu to COVID in New York City, which is the number one hotspot, you have to compare similar numbers. The highest weekly flu cases for the week ending February 1st for the flu was 8,600 cases. So that was the highest week in New York City. The highest week for COVID cases reported ended March 30th, and that was 5,500 cases. So the highest week for flu and the highest week for COVID, the flu was 8,600 cases, COVID was 5,500 cases. So the flu still wins in that situation. This was once again despite the flu having a vaccine and it being technically underreported. Now, important information from Johns Hopkins as of April 10th. Worldwide cases of COVID were 1.6 million. Worldwide cases of the flu, 1 billion. In the United States, cases for COVID through April 10th were 466,000. Cases for the flu were 45 to 50 million. So worldwide deaths are the number that everyone focuses on. Worldwide deaths for COVID as of April 10th, 96,000. Worldwide deaths for the flu, 646,000. United States, for April 10th, COVID deaths, 16,000. The flu, 61,000. Once again, the flu's got a vaccine, lesser requirement for reporting. So despite the flu being technically underreported, and of course you could argue COVID too, the flu greatly outnumbers that.
Yeah, that's very clear and quite interesting. I think that people are just starting to kind of grapple with this. Obviously, we do know a lot more now. That's what I think people need to understand. The science and data has evolved now, and just what Tom's relating, we didn't necessarily know a month ago. We couldn't say that a month ago because we didn't know, but now we do. And I think that it's becoming more clear. I would at least put it that way. So, all right. So Tom, my last question is, the big question I think for most Americans and a lot of people around the world is, when am I going to be able to get back to work? When am I going to be able to go out and do the things I, normally did within reason? When am I going to be able to open my business back? And certainly for you and I being surgeons, when are we going to back to treating our patients, that sort of thing. So what are your thoughts based on the way the science and data is evolving, which is going to lead the way for this?
As we get more real numbers, this is what really determines what we can do. There's the real possibility that a lockdown of the entire population may actually worsen the problem because you're decreasing herd immunity. You're decreasing the herd immunity early. But people have to get back out. People have to get back to work. The economy can't withstand a total shutdown or a large percentage shutdown for very long without causing significant long-term problems, including a mortality for shutting down the economy in and of itself. People who need to be treated for other medical problems right now are not getting the treatment they need because hospitals are focusing on COVID, and people are afraid to go to the hospital, afraid to go to their doctor. Hospitals, doctors, nurses all need to get back to work. Aside from a small number of hotspots such as New York City, many hospitals across the United States are actually fairly empty and staff are being laid off. The numbers show, however, that even in the hotspots, the numbers are decreasing. And I was just before we started, just now, I saw numbers out of New York City, and the case rate is actually dropping quite a bit on a daily basis. Now, of course, we have to say that all of this is dependent on the development of a COVID vaccine, and of course, the Israelis are well on the way to developing that. There's a possibility of a COVID vaccine. Being out within just a few short months, based on what they're doing. Until that time, we still need to have isolation of the high-risk group. That's the elderly, that's people with heart and lung disease, smokers, vapors, obese. Obesity is a significant risk factor with COVID. Once a vaccine is developed, all of this is going to go away. The COVID thing is going to turn into a low-grade seasonal flu that is going to be less than the current seasonal flu, which is the H1N1 flu. Now, to speak to my fellow surgeons, and how do we get back to work? In Texas, there's currently a ban on elective surgeries. It ends later this month. When a vaccine is developed, once again, this all goes away. But until then, my thoughts are, as far as aside from emergency cases, for those cases that are semi-elective, in other words, somewhat urgent cases, big cases that really should go to surgery, really there are two tests that are important. It's the test for the virus, and it's the test for the antibody, and specifically IgG. That's the antibody that indicates long-term immunity to COVID. So in those cases, those big cases, elective cases, semi-elective cases that need to go to the surgery, the sequence of testing that I've come up with is you first test for IgG, see if the patient is immune. If he or she is immune, that patient can go to surgery. If the IgG is negative, and although the patient is not immune, then do a viral test. If the viral test is negative, then go to surgery. They don't have the virus. If it's positive, obviously they have the virus. Wait till they get over it, and then surgery can proceed. Once testing is done. For purely elective cases, for instance, Bill and I do a lot of cosmetic surgery. Until a vaccine is developed, is testing actually necessary? Well, to put it into a different light, we don't test for the seasonal flu before surgeries. And as we've shown, the seasonal flu has much higher numbers, much higher mortality than COVID, but we don't test for it. If it's felt that testing is not necessary, then we just need to use common sense. And once again, until a vaccine is developed, probably best not to operate on someone with significant comorbidities, significant high-risk population. And if someone is elderly, delay surgery until we come to a time where we've got a vaccine. For any patient, the real common sense, and this is kind of my gut feeling, is for elective cases when we're able to do them, since we don't test for the flu and it's a healthy population that we're dealing with, if anyone comes in with upper respiratory symptoms, cough, cold, even runny nose, even though that's not necessarily a COVID symptom, or if they have any fever, including a low-grade fever, don't operate on them right now. Just wait until their symptoms are gone or their testing is negative. And then once the vaccine is developed, everything changes and we go back to normal life again someday, soon.
All right, Tom. Well, listen, that's great stuff. Very clear. Really, thank you. And, obviously we'll be back next week. I think we're going to more information. I know you'll be involved with that. So thanks again. And this is No Spin Live 101. If you want to see more of this, you can see it on the plasticsurgerychannel.com.